الموضوع النهارده هنتكلم عن النون-toxic multinodular goiter. I will start with clinical case, and through this clinical case, I will speak about definition, etiology, pathogenesis, symptoms, physical examination, routine investigation, imaging method, and fine needle aspiration, biopsy, and what about the treatment. This patient is 50 years female patient living in moderate iodine deficiency environment, came with complaint of swelling in right side of the neck for 10 years. Initially, the swelling was small, then gradually, progressively increased. And the patient has history of dyspnea and anxiety, and there was no history of associated pain, insomnia, tremor. This means no evidence of inflammation, no evidence of thyrotoxicosis, hoarseness, no hoarseness of voice, and this decreased the incidence of malignancy in this patient. There's no stridor, no dysphagia, and no protruding eye. This means we will exclude the Graves' disease or compression manifestation. This is from the history of the patient. We can take some points as a clue for this case. Regarding physical examination, a large mass was with the solitary nodule present in the right side. The mass extending from above up to the cricoid cartilage, below into sternal notch, laterally to sternocleidomastoid, and by palpation it's 12 by 10 centimeter. This means it's large mass, and we must look deeply in this mass. Which was nodular, moving with deglutition. This means no fixation to underlying structure of the skin. And this another clue that this mass is benign most probably. The left loop was nodular, but not significantly enlarged. The lower border cannot be palpable. This means I must search about retrosternal extension if we cannot detect the lower border. The rest of the thyroid was diffusely enlarged and nodular, and there was no bruit and no hyperactivity. The patient's systemic examination was within normal. By routine investigation, within normal range, everything was normal. And regarding thyroid function, the patient was euthyroid, and by ultrasonography, the thyroid showed grossly enlarged thyroid with multiple nodules noted in entire thyroid. And from this history and the examination, this denoting that the patient has multinodular goiter, and from this finding, we will speak about what is the multinodular goiter, at what time I will name this mass as multinodular goiter, or the different, we give the normal or the accurate diagnosis about this case. What is the meaning of goiter? It's enlargement of the thyroid more than 2 standard deviation. And thyroid nodules are very common. And some of this nodule may harbor malignancy. This means the most important point for us, if we find a thyroid mass, to exclude this mass's malignancy, because the management is completely different, either it's benign or malignant. The multinodular goiter, its name multinodular goiter, if the thyroid has no dysfunction during history and examination. And more descriptive and accurate name, it's nodular thyroid disease. And this is the most recent, it's nodular thyroid disease. At what time we name this simple nodular goiter? If there is no autoimmune disease, thyroid disease, no thyroid function disorder like this patient, we will name this mass as simple nodular goiter. And non-toxic diffuse goiter, if the thyroid gland was enlarged and the TSH was normal and the thyroid profile was normal at the same time. And after this history and this scenario, we will come to the etiology. What is the cause of the multinodular goiter? Previously, when I started to start for endocrine specialty, the thyroid disease was a little bit not common in the community. But nowadays, we find this very extensive and a lot of cases are present. What is the problem? What changes in our community leads to the thyroid diseases increased like that? The etiology of the goiter, it's a genetic environmental iodine deficiency. Iodine deficiency, it's usually the disease of young children and young adults, but the genetic and environmental factor, it's coincide together. If the gene is present and the condition of the patient has a family history and genetic predisposition, in addition to the environmental factor, which is act as epigenetics, this leads to the occurrence of the thyroid diseases. Regarding the genetic factor, this gene, there is no single gene leads to this problem. And if there is family history, the risk of the thyroid increase from 5 to 10 times more than the absence of family history. What about the thyroglobulin gene? It's stimulant. This is a gene which is present on chromosome 14, and this is responsible for transmission through the family. And this gene is responsible for thyroid hormone synthesis. In absence of this gene, the TSH will decrease and hypothyroidism will started, and the thyroid gland will enlarge and associated with hypothyroid. And this exactly named dysharmonogenesis. And recent age, before puberty, we find decreased achievement, school achievement, and stunted growth of the children at this age. And this is usually dysharmonogenesis. And if you find this problem in young children, we must search another problem in the family. And what about the environmental factor? I will give you a hint about the environmental factor, which is collectively the pollutant which is present in our community. Whatever the cause of the pollutant either leads to iodine uptake inhibitor or hormone receptor blockage or increased turnover of the T4, all these problems present in the pollutant which present in our community, like perchlorate, thiocyanate, which present in pesticides, present in plastic, present in a lot of the things, and this soil and some of the fertilizers which we use in the agriculture, and all this substance leads to epigenetic factor which stimulates the gene and leads to multinodular goiter. There is some dangerous problem like the dioxin and the polybromide diethyl esters, which is a plastic substance which is present in the feeding bottles of young children, and also present in the bottle of water, plastic bottle of water, which we use. It's containing a pollutant substance which leads to multinodular goiter, and this is the cause why this problem become common now. On the other hand, non-iodine factor like selenium, cigarette smoker, goitrogenous diet, and alcohol, medical drugs, insulin resistance, and socioeconomic levels, which expose the patient to more pollutant. And for this selenium, a lot of us giving the patient, in case of hypothyroidism, selenium in addition to thyroxine therapy. And also goitrogenous substance like cabbage or radish or something like that. And a lot of patients come to you in the clinic and ask you, what about my diet? What is the diet which increase or improve the problem of thyroid disease? We must know this type of diet which increases the problem. Regarding the medical drug, it's very common, like lithium for a long time, amiodarone, which used for treatment of arrhythmia, and tolbutamide and the other substance, oral contraceptive pills, which increase the estrogen level, and all these substances we must give the patient with goiter this drug cautiously. And if we give the patient this medication, we must search for the thyroid profile later on. Regarding insulin resistance, they found that 53% of the patients with insulin resistance have goiter, while 19% only in non-insulin resistant patient has goiter. This means there is strong relation between insulin resistance and goiter. And they found that the metformin use decreased the size of the multinodular goiter without using thyroxine in treatment of the patient. Sorry. Regarding the pathogenesis, deficient hormone leads to inflammatory response of the follicular cells and the enlargement of thyroid gland, and usually give the multinodular goiter with hyperplasia of the follicular cells. What are the symptoms which we find in our patient or you find in many patients in your clinic? The symptoms depend also on the activity of the gland and its hyperfunction or hypofunction. Regarding the size and function, this means the size, usually we ask about the vocal cord, the voice changes, compression manifestation, dyspnea, dysphagia, or something like that, denoting that the gland making compression at its place. And regarding the function, either hypofunction or hyperfunction, we must ask every patient about this manifestation. Also, the patient may come accidentally discovered in our clinic with a symptomatic case. And it's a lot of cases. For this reason, you must examine the thyroid gland of every patient coming to your clinic, even for control of diabetes or even for any problem. It's better to check the thyroid gland of the patient. Also ask the patient and check for compression, hyperthyroidism, and hypothyroidism. Regarding the local symptoms, there is the Zucker-Kandeel tubercle. This Zucker-Kandeel tubercle here. If this Zucker-Kandeel tubercle increase in size, it will make compression on the esophagus and leads to dysphagia of the patient. And this is one of the causes which leads to take the permission or giving the patient permission for operation. Also, hoarseness of voice and the stridor, it's dangerous manifestation. We must send the patient for the doctor for ENT doctor to check for the vocal cords with indirect laryngoscope. Regarding physical examination, inspection, palpation, and we will check about the consistency, size, and everything of the gland. And regarding palpation, check for this any thrill it's present or any tenderness or something like that. Retrosternal goiter, this is a positive Romberg sign. And we ask the patient to elevate her hand like that, and we decrease or flex their face or the head on her neck. If we found there engorgement of the neck veins or plethoric face, or the patient feeling of difficulty of breathing, this means positive Romberg sign, and it's mean retrosternal extension, and it's better to send the patient for surgery if the patient didn't respond to the treatment and the gland didn't decrease in its size. Diagnosis and treatment of non-toxic multinodular goiter, it's by chemical test to treat it's clinically, and imaging method, invasive and non-invasive method. I will give concentration on the imaging method because all of us, we find this ultrasonography, we send the patient at first for free T3, free T4, TSH, and thyroid antibodies. And after that, we ask the patient to make this ultrasonography. And the ultrasonography, it's a non-invasive, very simple maneuver. And through this ultrasonography, we can take a decision about send the patient for radioactive iodine uptake or fine needle aspiration or something like that. And also by ultrasonography, we can detect the presence of malignancy or absence of malignancy. Through the biochemical test, we make TSH, free T4, free T3, and regarding the imaging by thyroid ultrasonography, and there is recent imaging techniques like ultrasound elastography and we will speak about when we will send the patient for ultrasound elastography and thyroid scintigraphy and the indication for this, and cross-sectional imaging by CT and MRI. By ultrasound, it should be the first choice for imaging method. It's non-invasive, cheap, and giving us the idea about the volume, shape, location, structure, and vascularization of the gland, and can differentiate between benign and malignant nodule. And this is the most important point in our lecture. Okay. And this is the ultrasonography. And some also about the and also about the presence of this is punctuate, the punctuate calcification, and this is the capsule. It's irregular in shape, okay, and also there is invasion here, and there is calcification, and also invaded this, the nodule from inside, it's invaded by some of the tissues, which denoting that most probably this case is malignant, and also this patient needs for biopsy, fine needle aspiration biopsy. And these features, I will illustrate these features: capsular invasion, presence of metastatic lymph node, and if you find in the lymph node, we must look about the medulla and the cortex of the lymph node. If we find a good differentiation between the cortex and the medulla, this means it's benign and most probably inflammatory. But if there is absence of good differentiation between cortex and the medulla, this means this thyroid nodule may be malignant and it may be metastatic. Also, prominent hypoechogenicity, mostly a solid nodule, and if we find the nodule with the fluid inside without any tissues, this means it's completely benign. If the nodule is taller than wide in shape in the anteroposterior section, this means it's malignant. Infiltrative or lobulated margin, this means malignant. Microcalcification, irregular or interrupted peripheral calcification. This means if you find any of these findings, you must check for the radioactive iodine uptake and to detect the best position for taking the biopsy. Or if the patient, the doctors, if you have a good doctor for ultrasonography, you can do this fine needle aspiration guided biopsy by ultrasonography. And this is another picture for the ultrasonography, and this is the most important point in our lecture. And this is benign, and the incidence of malignancy is 1%, and it's very good rounded border without any calcification in the border and no tissue inside this fluid, and this is cystic fluid. And this very low suspicious of malignancy because it's regular. We told that the malignant is taller than taller in upper border, and this nodule is wide from the transverse line. It's not taller, and this is low suspicious from 5 to 10%. This is the heterogeneous calcification, and it's merely rounded without any invasion of the capsule and low suspicion of malignancy. And here it's suspicious of malignancy, it's rounded calcification like that. And this heterogeneous, and this some tissues present inside, but it's highly suspicious of malignancy from 70 to 90%. It's punctuate calcification, and also there is invasion of the capsule, lobulated boundaries, and from the ultrasonography you can detect this ultrasonography for benign or malignant. What is the problem? A time.
We can give her some minutes. Yes,
oh,
please.
I'm sorry. I'll finish rapidly. What about the thyroid imaging reporting and data system? We find in the ultrasonography Thyroids, and Thyroids, it's a categorization of the imaging reporting the data system, and it's assign the composition, echogenicity, shape, and margin, and P9, it's TR1, and with increasing the number up to 5, with increasing this number denoting that it's a dangerous nodule and the patient needs for fine needle aspiration. The ultrasound elastography, if you find the gland is hard and there is, we cannot differentiate between benign and malignant, we can send the patient for ultrasound elastography. And the cross-sectional computed tomography, if there is retrosternal extension or invasion to the nearest structure, we can send the patient for CT or MRI. Scintigraphy to detect the cold nodule and detect the best look which we can take this biopsy from this area. Positron emission tomography, it's not needed, but sometimes we find that with accidentally detect that there is some malignancy present in the lymph node of the neck. Fine needle aspiration, if we have suspicious of malignant nodule everywhere, anywhere in the gland, we can send the patient for fine needle aspiration to detect either the patient will do, the surgeon will do total thyroidectomy or partial or total thyroidectomy or no. The treatment, it's a clinical, either clinical follow-up in the simple case without compression or levothyroxine suppression treatment. We can give the patient with normal thyroid profile without the changes in T3 and T4. We can give the patient very small dose of L-troxin. Sometimes it decreases the size of the gland by about 50%. And radioactive iodine treatment, some cases giving radioactive surgical if there is suspicious of malignancy or compression manifestation.
Thank you so much, Professor Hanaa, for your elegant presentation.
Any question?